Hello guys, hi, welcome to Med School today. So we're just going to discuss today hyponatremia. So we are going to discuss 3 MCQs on hyponatremia. So I'll present an MCQ, then you take a minute or so to think about the MCQ, and then you can actually think about the answer. Then I'm going to go on to the answers then. Okay, without wasting any time, coming to the first MCQ. So I'm just going to read the statement to you as well, and then obviously you can read with me. So it's a 58 years old male with a long-term smoking history. He presents with a 3-month history of progressive weight loss and a persistent cough. He denies any recent infections or any changes in medications or any family history of any similar symptoms. On examination, you found him to be euvolemic. So that means he's not hypervolemic or he's not hypovolemic, he's euvolemic. And his initial blood test shows low sodium, low serum osmolality, urine sodium 45, urine osmolality 300. In the context of this patient clinical presentation and laboratory findings, which of the following is the most likely diagnosis? A. Primary polydipsia, B. Psychogenic polydipsia, C. SIADH, D. Cortisol deficiency, or it's E, which is hypothyroidism. I'll let you think about this question, and obviously you can pause the screen as well, and I'm going to move on to the next page, which will entail an answer. So you can pause the screen now and take however time you take, and then you can move on to the next page. Okay, so the right answer was SIADH. And so there's a diagnostic criteria for SIADH. There were a few hints in this question. A, the patient was a smoker, and then he had weight loss, which tells smoking weight loss, it could be a cancer. And you know that small cell lung cancer is associated with SIADH, so that's the biggest hint. And other hints were obviously the lab values in which the sodium was low, the plasma osmolality was low, and then the urine sodium was high, which was around 40. And then patient was euvolemic as well, which is like SIADH patients are euvolemic. They are not hypo or hypovolemic, they are euvolemic, which is very important. And because SIADH is a diagnosis of exclusion, so you literally have to exclude other possible causes of hyponatremia in a euvolemic patients, which is your adrenal and thyroid dysfunction, which is important. So the diagnostic criteria of SIADH, as it's written here, is like you have to be hyponatremic, less than 135. You have to be, your plasma osmolality have to be low, because if your sodium is low, that means your plasma osmolality is low, because plasma osmolality literally contains sodium in its formula. And you see here the urine osmolality is high, which is like not really high, but more than 100. And urine sodium levels are more than 30 to 40 to diagnose SIADH. What does that mean is that despite having this dilute blood, like hyponatremia in the blood, what kidney should be doing is try to get rid of extra free water in the kidneys to make the sodium normal. But that's not what is happening here. You still see a relatively concentrated urine with more sodium. So you see a concentrated urine with more sodium. So that means ADH is acting more, because ADH causes water absorption from the kidneys into the blood. So it will actually make the urine concentrated and increase the sodium in the urine, because the water is actually entering the bloodstream, making the rest of the urine more concentrated. So these are the diagnostic criteria. So you have to have a hyponatremia, low plasma osmolality with relatively high urine osmolality, which means concentrated urine with high sodium in urine. Normally the urine sodium level, the spot urine sodium level should be around 20. In this case, it's like more than 40. And then obviously clinically the patient should be euvolemic, and you have to, because the SIADH is a diagnosis of exclusion, so you have to rule out adrenals and thyroid dysfunction. So you have to send the cortisol levels and you have to send the TSH. And obviously there should not be any diuretic used recently, because that will mess up your urine sodium levels anyways. It will cause falsely high urine sodium levels, and then you can't really diagnose SIADH. So we've already discussed these things. So we know this patient is having urine osmolality of more than 100, and with the urine sodium more than 40. So that take in the context of euvolemia, which becomes SIADH. And also we had few hints in this question of being a chronic smoker, weight loss, persistent cough, which raises the possibility of it to be a small cell lung cancer. and then which is associated with SIADH. The other choices in these questions were primary and secondary polydipsia, which is unlikely because in these cases the urine will be very dilute. But in our question, the urine is actually concentrated, so that kind of rules out polydipsia, because if you're drinking more water, your urine will be dilute. But in SIADH, urine is concentrated because ADH is acting more on the kidneys to concentrate it more. And cortisol and hypothyroid deficiencies, which were there in the question, you can't really tell because there was no value given of the TSH or cortisol level. So you can't really say that in the question. And just to quickly talk about the hormones from the pituitary, because we obviously have discussed over the vasopressin here. It's a common question in an MRCP exam, PLAB exam, that where is what secretes vasopressin? And then another question is what releases vasopressin? So you know the vasopressin is actually produced in hypothalamus by superoptic nucleus. It is produced by hypothalamus but released from pituitary, which is important. So hypothalamus would produce it, then send it across to posterior pituitary, which then releases into the blood. So you have to really watch the question, what exactly they're asking. Are they asking where is it produced, or they're asking what releases it into the blood? So which is important. And you know when ADH is released into the bloodstream, it actually on the V1 receptors or the V2 receptors. And this question also come quite commonly, that V1 receptors are actually in the blood vessels, it causes vasoconstriction, where the V2 are in kidneys and they cause water retention, which we've already discussed. Obviously, the other hormone released by the posterior pituitary is oxytocin, which is again released by posterior pituitary but actually produced by hypothalamus. And this is kind of a broad perspective of how to literally go about with hyponatremia. We're not going to discuss this in video. Our patient was here euvolemic hyponatremic. So there are literally three things possible: SIADH, hypothyroid, or glucocorticoid deficiency. As I told, SIADH is a diagnosis of exclusion, so you have to rule out hypothyroid and glucocorticoid deficiencies before you make a diagnosis of SIADH. And obviously you can pause the video and see more in this table, but we're not going to discuss this table for now. Okay, next question. So in the same patient which you see in question 1, what is the most appropriate initial management of this patient with SIADH? His sodium levels are 127 and he has got no neurological symptoms. So now you have diagnosed the patient who have SIADH and his sodium is 127. How do you, with no neurological symptoms, how do you treat it? So choice A would be give him 3% normal saline. Choice B is fluid restriction. C is tolvaptan. D is demeclocycline. E is high dose corticosteroids. You can obviously pause the video and then think about the answer. I'm going to go on to the next slide, which will entail the answer. In this case, the answer is fluid restriction. For SIADH patients, once you have diagnosed these patients, the first thing to do is fluid restriction. That's the first line of management. So if you restrict the fluid, eventually that will help to reduce the total body water loss. Excess. And then because SIADH is literally reabsorbing the water you're drinking, and then that is diluting your sodium. So if you're drinking less water, less is getting reabsorbed, so less likely it will dilute your sodium. So it gets to a new osmotic level then. So fluid restriction is the first line management. But having said that, if the patient is actually having severe hyponatremia, especially less than 120 levels, plus having neurological symptoms like severe headache, seizures, then hypertonic saline becomes the first line of treatment, which is important. So you have to really look into the question, what are they asking? If this very same patient was seizing or having seizures or having a sodium of, let's say, less than 120 with symptoms, then the choice would not be fluid restriction, but actually hypertonic saline, which is a 3% or 5% depending upon what country you're based in. Other choice was tolvaptan. Tolvaptan is actually a vasopressin receptor antagonist. This is, again, it is only used when the above measures have failed, like the fluid restriction has failed in patients, and then it's not a first line of treatment. So you just reserve it to patients who have not responded to your fluid restrictions. So that's good to know that it's not a first line, not generally a first line treatment. Again, a demeclocycline is it's an antibiotic which belongs to tetracycline group. Its side effect is actually causes nephrogenic diabetes insipidus. So it kind of blocks the action of ADH on the kidneys, and we can use that side effect to then give an SIADH, if that makes sense. So it kind of blocks the ADH action on the kidneys. So you can potentially give an SIADH, but again, it's not commonly used because of the side effects, and it's not a first line as well. So yeah, high dose steroids have no role in treatment of SIADH. That was a fifth choice, so that's no. Why would you give steroids? Because steroids literally causes more free water absorption from the kidneys. So you can literally make the situation more worse by giving steroids. Okay, coming on to the last question now. A 58 years old smoker now has a severe hyponatremia with sodium of 115, and it was treated with 3% of hypertonic saline. As we already discussed, that if patients having a severe hyponatremia, you have to treat with 3% saline, hypertonic saline, because you have to correct the sodium because patients are symptomatic with that low sodium levels. His serum sodium is in 24 hours from his correction was 130. So it was 115, and after 24 hours, it was 130. So rise by 15. So next day, he developed neurological symptoms including difficulty speaking and swallowing and altered mental status. What is the most likely diagnosis for this patient's new neurological symptoms? Stroke. B is central pontine melanosis. C is worsening of his underlying lung cancer with brain mets. D is meningitis or encephalopathy due to hypertonic saline. So what of these 5 choices is the correct answer? Which of these 5? So this patient is literally the same patient with now severe sodium, low sodium. Now we have given 3% saline. His sodium has gone up to 130 in 24 hours. Now he's developed these symptoms. So you can think about this. Take a minute to think, and then I'll move on to the next slide. You can obviously pause the slide. The correct answer here is central pontine melanosis. Again, a very important common topic which comes in MRCP, PLAB, UKMLA, USMLE exams. So this usually happens once you have corrected the low sodium very quickly. In this patient, we corrected the sodium by 15 in 24 hours. The recommended level of correction is not more than 8 millimoles a day. So if you correct more than this level, then you are in the risk of getting this problem, which is central pontine melanosis. The name does suggest there's a problem with the pons. And then it's a fatal condition which occurs when you correct it too rapidly, as mentioned here. So again, you have to remember 8. So 8 to 10, some say 6 to 8 is kind of a magic number, which you should not correct more than if your patient is having low sodium. And because in our case patient, we corrected it very quickly by more than 15, the patient has developed CPM, which is central pontine melanosis. It's also called osmotic demyelination syndrome. The risk factors of developing this syndrome is obviously one is like correcting it too rapidly. Other is chronic alcoholism, malnutrition, liver disease, severe infection, burns and cancer. Because in these conditions, your already water balance and sodium balance is messed up. And add to that, you've corrected it more quickly, then you are more prone to demyelination in your bones and other structures. On an MRI, this is how it looks like. You see hyperintense changes on an MRI around the pons area, and then symmetrical hyperintense changes in the central bones on T2 weighted images. But again, there are also extra pontine areas of involvement. So it's not just central pontine melanosis. That's why they've changed the name to ODS, which is osmotic demyelination syndrome, because other areas, extra pontine areas like basal ganglion, thalamus, cerebellum might also be affected. And usually the imaging changes takes around several days to week to pair. The symptoms might pair earlier. Okay, thank you so much.